Hello.
Hello.
Hi.
I'm not sure why the broadcast is now starting. Hi, Tina. Hang in there.
Oh, it's
Okay.
probably because I hit the *1.
Well, good afternoon, everyone, and welcome to today's presentation, Improving Patient Outcomes for Hypertension and Diabetes. My name is Cindy Eisman, and I'll be your facilitator today. At this time, all attendee lines are muted for this session to minimize background noise and distractions. We encourage your questions and input throughout the presentation, so please feel free to use the raise hand icon in your taskbar or submit questions or comments in the chat box provided. Today's presentation will include polling questions. We encourage everyone to participate as we value your interaction. Today's presentation will also be recorded and later uploaded to our HealthVisions Delmarva YouTube channel. You may find the link on the flyer that was included in your invite to today's webinar and also in the handout section on the control panel. Today we're privileged to have two guest speakers, Karen Ziecker and Kevin Massino. Our first presenter is Kevin Massino. Kevin is the Cardiac Health Network Task Lead for Quality Insights Quality Innovation Network. In this role, he leads Quality Insights efforts to improve cardiac health and reduce cardiac healthcare disparities in West Virginia, Pennsylvania, Delaware, New Jersey, and Louisiana. He's been with Quality Insights for over 14 years. Kevin is a registered nurse with a background in physician offices, long-term care, home care, and managed care. He earned a nursing diploma from Brandywine School of Nursing and a Bachelor of Science degree in nursing from Immaculata University. And we welcome you, Kevin. Our second speaker will be Karen. You're welcome. Our second presenter is Karen Ziecker. Karen is a nurse and is currently Quality Improvement Specialist and Staff B2 Task Lead for Louisiana. She's been with EQ Health Solutions for over 15 years, serving on various CMS projects and tasks. In the 9th scope of work, she worked in the CMS pilot for bringing diabetes self-management education to her state. With over 40 years as a nurse, her main focus has been discharge planning, case management, and quality improvement. She received her BS in nursing from the University of Louisiana in Monroe in 1978. She's trained as a peer educator and a lead educator for the Diabetes Empowerment Education Program. Presently, EQ Health Solutions is proudly serving with Quality Insights as a Quinn QIO. I would now like to hand it over to Kevin, who's going to take it from here. And it might take just a second for that to change.
Perfect. Can you see my screen?
Thank you, Kevin. We can.
Great. Thanks so much for the introduction, and thank you to everyone for joining. Today I'm going to be going over a little bit of the history of the Quality Improvement Organizations, or QIOs, and also going over the project for which I work directly, and that is the Cardiac Project. I just wanted to give a little history of the QIO projects. The QIO started in 1984, and each contract or scope of work was 3 years long. So in the last contract that we had, or scope of work, CMS was doing things the way they had always done them, with 53 state-based QIO contracts. So each state had a contract and each territory. I tried multiple times to be transferred to the Virgin Islands, but that didn't seem to be an option for me. And there were 41 independent organizations. So what that means is some QIOs work together under a parent umbrella. For example, Quality Insights had the contracts for West Virginia, Delaware, and Pennsylvania. And in that work, we focused on 3 drivers: supporting competing learning action networks, providing technical assistance, and care support through innovation spread. When it came to the 11th scope of work, CMS decided that having all those different quality improvement organizations was too much contract work, and they wanted to simplify things. So in the history, we had both the beneficiary and family-centered engagement and the quality improvement organization work. So what CMS did was they separated those out. they had the beneficiary and family-centered quality improvement organizations be their own entity. So if anyone's been in the hospital or has been with a family member and you go to leave and they say, here's a piece of paper, call if you have any concerns or problems, that's what they handle. So they perform medical case review, and there's 5 of them across the nation. What we do, and the way we kind of changed, is now we're quality innovation networks with quality improvement organizations underneath. So we offer quality improvement and technical assistance, and for us to apply for those contracts this time around, each state couldn't do it individually. You had to have 2 to 6 states in the network. Another of the big changes was, instead of the 3-year contracts, we extended into 5-year contracts. One of the things that made us really happy about that was a lot of times, getting things going with practices and home health agencies, hospitals, whatever healthcare setting. By the time we felt that we were really working successfully with an organization, it was time to start something new. So it was really great for us to be able to have 5 years to do that work. And I won't go over this whole slide, but what CMS was really looking for the QIO program to do was the triple aim: better health, better care at a lower cost. Safer care is a huge thing, and this whole slide covers the triple aim. There's 4 key roles in the Quality Improvement Network, Quality Improvement Organizations. Champion local level results-oriented change. One of the things that CMS is huge on is data. They want providers to give data so they can see if the implementation of the different tools and best practices are actually making a difference within the practice and affecting the beneficiaries in a positive way. They really were looking this time around for patients and other partners to be involved in the work, and really having something that wasn't just checklist items or things that stuck, practices that, best practices that clinicians implemented and, maintained as part of their ongoing practice. We've been working with facilitating the learning and action networks and all teach, all learn environments, and really placing an impetus for improvement at the bedside level or the patient visit level, depending on what kind of facility. We've done a lot of technical assistance, and our other goal was to communicate effectively, to really have hands-on approach with the practices and other agencies that we've been working with. Here's a map of the QIOs. If you look at the mustard-colored yellow, you'll see there's Pennsylvania and New Jersey and Delaware and West Virginia. So as I said earlier, we had Delaware, Pennsylvania, and West Virginia in our previous contract. And New Jersey was an individual state who came to us, and we are working with them as a contractor. And the question I get most often is, how did you end up with Louisiana? Because of the geographical difference. But realistically, if you look around, there's several states with they're kind of spread out in their quality improvement networks. But Louisiana was working on their own, and they're subcontracting with us now as well. The settings that we work within are physician offices. CMS, as most of you have heard by now, is really big on the Million Hearts Initiative. They've just switched it to the Million Hearts 2022. Aspirin, blood pressure, cholesterol, and smoking cessation. We also work with home health agencies with the Home Health Quality Improvement. They're an entity that works with home health agencies nationally to provide them with ways in which they can provide better care to their patients. And they have a cardiovascular data registry in which they extract data from their OASIS visits with their patients and put that in, and they can track how they're doing on their blood pressure control or their smoking, things like that. And as I mentioned earlier, really working with beneficiary and families to engage them in the work. I think that in this project specifically, it's been one of our challenges because as Karen will talk about in the diabetic work, you're hand in hand when our staff is out teaching, where the work that we really do in cardiac is virtual. We're not really funded for on-site visits. So therefore, it makes it a little bit trickier for us because we're trying to reach beneficiaries through the physician offices themselves, which can be a hard task. I just listed the data collection measures that CMS outlined in the contract, things that they were really looking at. The big one for them is blood pressure control, and in that, seeing if blood pressure protocols have been implemented in practices. And they're not necessarily looking for a specific one. On the Million Hearts website, they've adopted a few as standards and also have a way in which a practice can build their own protocol. The next one, second highest on their list, is smoking cessation. Just doing that counseling, documenting correctly. And really the bottom two are the aspirin when appropriate and cholesterol. One of the issues with the cholesterol management, as you can see, they never received a national quality forum for that measure. So practices have been hesitant to really work on that measure specifically. So I mentioned that we do everything we do is virtually. So how do we approach those practices and home health agencies? We do monthly e-bulletins to the provider offices. We do webinars and recordings. One of our contract requirements on this project, which is a little different from some of the others, is that we are required to have monthly educational events. Sometimes we work with HHQI, the Home Health Quality Improvement that I mentioned earlier, and we work with a lot of our other partners as well, American Cancer Society, Million Hearts. The executive director of Million Hearts, Dr. Janet Wright, has recorded a couple webinars for us that we use as references. We do live chats, a lot of social messaging, and then just our big thing is posting tools. We have a lot of evidence-based resources and tools. The staff is making phone calls and emailing these practices regularly. And I'll talk in a minute about the next two, My Quality Insights and the data reports. So in our monthly educational events, as I mentioned, we really rely on our partners because one of the things that we don't want to do is take up time from a physician office doing something that they already know, information that they've seen a million times. So we try to make it new and exciting. And when we can get a great speaker, we really rely on that to do some of the work. So HHQI has done a lot for us. The Southern New Jersey Perinatal Cooperative and Family Health Initiative did a great smoking cessation webinar for us about different things that are being done in New Jersey specifically, but can be carried over into other states and other individual practices. From Louisiana, we had the Rowan County Family Health Care. They were one of the Million Hearts Hypertension champions, and they did a webinar for us on strategies to control the rates. My Quality Insight is our online educational platform. So we realized that emails fill up too quickly, that files are large and things like that. So what we developed was something online where a provider could go to have access to tools that they could implement in their practice, that they could shop around within this and say, well, this might work for me or this might not. So one thing I wanted to talk about is, anyone attending this webinar can contact us afterwards and have access to the My Quality Insights and become part of our project. So when you log in to the cardiac health piece, you'll see in the bottom of the screen, there's cardiac home health agencies or cardiac health practitioners. And then when that's clicked on, we just use a screenshot from the home health agencies, but they're really similar to the providers. And it just lists the different tools. If anyone has rated them, it gives a rating. And then there's a PDF and a way to view and download those. Our newest resource, which we've had a lot of good feedback on, is Understanding Your Blood Pressure Numbers. I realize it's small and hard to see, but basically goes over the new blood pressure guidelines from last year and does it in a stop sign fashion that can be used within the office to train people on the new measures and guidelines. One of our tools you'll see to the right is 7 simple tips. It's basically 7 things that can be done during a patient visit to get a more accurate blood pressure. So we had put this tool out there, and we had a practice manager in New Jersey who thought that this might be a great opportunity to improve their blood pressure control rates. So they did a PDSA cycle with the aim at improving, and they trained the staff on the 7 simple tips to make sure that the clinicians, the medical assistant, anyone that might be taking that blood pressure was implementing the 7 simple tips at each visit. So they had their baseline data, and then after they implemented this, they collected more data after 3 months, and the blood pressure ratings had a significant improvement. And so now anyone that comes into the practice as a new employee, it's just part of their policies and procedures that these 7 simple tips will be used for each visit. Another thing that was listed on the prior screen was our cardiac risk factors toolkit. And here you can just see the table of contents. There's clinical guidelines, benefits versus risk for aspirin therapy, for example, dosage. And that's another tool that is listed. And there's access to that on My Quality Insights. The other thing that I mentioned was our Quinn level cardiac reports. So anyone that is part of our project in those 5 states can submit data to us on their blood pressure rates. It's done on a cumulative calendar year. So for example, the first report of each year is just January 1st through March 31st, and then our 4th report of the year is January 1st through December 31st. One of the challenges that we've had is not all the EHRs are able to produce that data on the cycle that the providers are looking for. But you can see here, it's a sample office, but what it does is it breaks down each measure. It tells them how they're doing compared to the other practices and clinicians within their state, and then gives them the trending on how they're doing. And, you know, a lot of practices have used this just as a thing when they see a really bad tracking line that's really all over the place, just to go back and ensure that everyone's doing documentation in a similar way and that nothing's being lost. Because we work with physician offices on so many projects, we try to do as much as we can as far as cross-task collaboration. We have a team that works on MACRA and MIPS. So we do a newsletter that goes out from our project, the MACRA MIPS project, and the adult immunization project. And then in our patient beneficiary engagement, we work with the adult immunizations as well. A couple things that we have in the pipeline, we're working on a blood pressure e-learn that we'll post in My Quality Insights and people have access to at their leisure. And also we have a PharmD that's going to be speaking and doing a webinar on the effects of cardiac meds in the elderly. That is all I have. Are there any questions? Okay, well, we will then go to a polling question.
Okay, so I was on mute for that whole time, which is why we usually have Valencia doing these for us. I will tell you that 40% of the people in our poll said that they are a Delaware or Pennsylvania practice and would like to contact Quality Insights to participate in the program, and 60% were Maryland practices who also are interested in participating in the program as a partner. And we realize that for the Maryland practices, they can't participate in the data collection portion, but all the tools are available to you. So your practice advisor will be able to help you get connected and get those implemented and help you with implementation plans. Okay, Karen, I believe that I have your screen up now and we are ready to go with you.
Okay, great. Well, welcome everybody. I'm glad to be with you today, and let's see what we've got here. Let's go to the next slide with objectives, please. What we'd like to do today is, quickly learn about and understand the impact of diabetes around the United States and how the Everyone with Diabetes Counts program was developed to address that need. We also are going to talk a little bit about the Everyone with Diabetes Counts program and about us teaching the Medicare beneficiaries and how providers really can implement this into their own practices. Next slide. Two out of every 5 persons, Americans, are expected to develop some type of type 2 diabetes in their lifetime. And so we're starting to see that these numbers have continued to climb. Next slide. Unfortunately, 1 in 4 or 29 million Americans have diabetes and they don't even know it. Next slide. This is a really neat infographic. If you haven't seen it, it tells the story in pictures. In the last slide we said it says it's 2 out of 5 Americans will develop diabetes in their lifetime. And in this slide provided by the American Diabetes Association, it's 1 in 11 Americans are affected by diabetes. One of the things that we're looking at is including the children who would develop diabetes in their lifetime. It's hard to comprehend that type 2 diabetes in children was virtually non-existent 15 to 20 years ago, maybe a little longer, but with the advent of our video games, trips to the fast food restaurants, and lack of exercise, and many other factors, but it's led to a monumental increase in type 2 diabetes in children. And as of 2017, it now costs about $322 billion for those with pre-diabetes and diabetes. And when I first started doing this project, when we did the little pilot back in 2009, I think it was, in the night scope of work, it was costing about $245 billion at that time. So you can see the difference just in the last few years of how it's gone up. Next slide, please. One of the things that I wanted to mention, and I was so glad that I was able to share this webinar with Kevin, is that we have such a perilous friendship of heart disease and diabetes. And so those two things for education purposes work hand in hand, as most of us know. So a lot of things that we're talking about and trying to prevent and complications and things like that we're able to cover and collaborate on within the diabetes program and education program. But as you can take a look here at this slide, the diabetes prevalence by race and ethnicity. The Everyone with Diabetes Counts program targets most of these disparate populations in any way that we can. And as you can tell, we've got the 16.1% of American Indians and Alaska Natives all the way down to your non-Hispanic whites, 7.1%. Next slide. So let's talk a little bit about the Everyone with Diabetes Counts Medicare project. Next slide. So what is the EDC? First, I want to give you a little history about Everyone with Diabetes Counts. Way back, like I was saying, in the ninth scope of work, we started this little project. CMS found favor with it. It was when we first piloted it, it was Washington, D.C., Louisiana, Georgia, New York, and the U.S. Virgin Islands. And as we worked to look at the barriers and things like that and report those things, they did see that there was a lot of potential of reaching those that were in the rural areas and those beneficiaries and people that did not have access to education. So after CMS found favor with it, it moved to a special innovation project, or what they call a SIP, in the 10th scope of work. And this is where West Virginia became involved and became a lead. And so as you can see, our concentration in this area was on rural beneficiaries. They had 8 project coordinators that taught all over the state and eventually reached over 1,500 Medicare beneficiaries while teaching a total of around 2,000 people. Then in 2014, with the success of it, documented success, then it was rolled into the 11th scope of work, and now it's the largest national Medicare diabetes self-management education program. Next slide. Our Everyone with Diabetes Counts project and focus is based on several things, but our strategies and what we really wanted to accomplish was to look at the clinical measures, looking at our patients' A1Cs, eye exams, lipid profile and blood pressure, and food exams. Were they getting them? Could we decrease the disparity by population and improving the frequency of the testing for these? We also, in these clinical measures, in the process of our Everyone with Diabetes Counts program, we pre-test them to see what their knowledge base is in the actual program of DEEP, and then we also do collect pre-information up to 18 months before on these measures of the A1C, eye exams, and lipid profiles before they even take a class, and then post the class up to 1 year after completion. So we have good clinical data, and we also have some testing data that we do as we're providing the class to them. And then data is always important so that we can improve actual clinical outcomes of the diabetes measures and so on. We target all of these entities to partner with, to host classes, refer patients, and it's important. I know that we had to work here in Louisiana to increase our referrals from physician practices, and we now have begun to really get some established physicians interested in continuing to refer on a consistent basis now. National partners, local partners, everyone becomes involved, and it's can be a collaborative effort when all these communities. Next slide, please. We try to find those practices in the very most rural areas to work with because, as I noted before, most beneficiaries in the rural areas do not have access to a DSME class. When we teach these classes, we must use an evidence-based program, and the main one that's used in West Virginia is the Diabetes Empowerment Education Program called DEEP, and this is what we also use in Louisiana. Our classes are 1 day a week, 5 to 6 weeks in length, and last about 1.5 to 2 hours. So what do we cover? And we cover the module 1. There's 8 modules that we cover, and in the beginning, the number 1 is beginning sessions and understanding the human body, establishing and reminding beneficiaries of their anatomy and how the body works and physiology. Module 2, we look at risk factors and how those risk factors may be playing a part in their diagnosis. Module 3, monitoring your body, looking at hypo and hyperglycemia and how to monitor effectively. Module 4 is get up and move with physical activity and diabetes. Module 5 is controlling diabetes through nutrition. 6 is diabetes complications with identification and prevention of those complications. Module 7, learning about our medications and medical care. And as we know, medications change very rapidly sometimes. Even side effects are discovered, and so there's a lot of information that needs to be transferred during that time. Living with chronic disease and mobilizing family and friends is our 8th module. But in all these classes, we set goals for behavior change, and it's up to the individual beneficiary, but we encourage them to make an action plan that helps them to address their needs on a weekly basis, and we find they are more encouraged as they see results, and they start to see that their setting of the goals and putting their action plan into place is they are achieving results. Now, beneficiary, once they complete this class, they're considered completed once they do 5 out of the 6 classes. They're considered that they can graduate. The stories that come out of these graduations are just wonderful. Very personal things of them implementing their action plans and making changes such as loss of weight or monitoring themselves differently or understanding their medications and how they work. So very important stories to share. Okay, next slide, please. Diabetes self-management education and support. Let's move on to the next one. Most of you know about DSME, but this is the formal definition, I guess, from AADE. It's the ongoing process of facilitating the knowledge, skill, and ability necessary for diabetes self-care. It incorporates the needs, the goals, and life experiences of the person with prediabetes and diabetes that is guided by evidence-based research. And it supports informed decision-making, self-care behaviors, problem-solving, and active collaboration of the healthcare team to improve quality of life of those with diabetes. We try to follow this definition to ensure that all those that come to our class leave with a sense of empowerment regarding their own health care. If they attend and have achieved at least one goal, then as educators, we feel comfortable that the change can be incorporated into their daily lives. Next slide. This infographic demonstrates how closely the elements of the curriculum that I mentioned in DEEP, such as understanding the human body and so on, understanding risk factors, how it relates and aligns with the AADE core elements. Next slide. The benefits of DSME to patients. Patients who receive diabetes self-management education have all these things, have improved use of their primary care and prevention services. They seem to know how to relate better now, how to ask questions that will help them self-manage. And when they have those answers, then they seem to be able to better control their glucose, their blood pressure, and then that relates into lower health costs. We have found that those that take DSME seem to even want more education as they continue in this process. Next slide. So why do we need referral to diabetes self-management education? Well, let's look even below, right there in the medication, the monitoring, and the exercise and weight loss, those key points. Diabetes self-management education works. It's an evidence-based intervention that increases the knowledge and skills of patients with diabetes to improve their health outcomes. their ability to self-manage their disease, to promote the quality of education for people with diabetes. And the American Diabetes Association endorses the national standards for DSME and as the basis for ADA recognition and the American Association of, which is the American Association of Diabetes Educators also. Both certifying bodies recognize DSME as a collaborative process by which people with diabetes gain the skills and knowledge needed to modify their behavior and then successfully manage the disease as it's related to conditions. Okay, so as you can see, in this slide, looking even at just medication monitoring and exercise and weight loss, the importance of referring patients to a DSME class. Next slide, please. Referring a patient to work with a diabetes educator and supporting that interaction with the provider follow-up will ensure better outcomes for the patient. And sometimes that becomes easier. Sometimes it takes a little while to develop this in the referral process. I know in one clinic that I've been working with, it's taken me probably about a year to smooth out a process for referral for DSME. But now the nurses feel comfortable enough to call me and say, I have these patients, these are the phone numbers, and I want to get them into a class as soon as you can. And so I'm able to have rapport with them and give them feedback on their participation. So another thing is incorporating reminders and follow-up procedures into the office procedures. Are you following up? You can dramatically increase the likelihood that patients will attend and complete self-management education and have access to critical information and support throughout the course of their disease. Because we try to give as much feedback as we can to our physicians' offices that are referring and the information that we gain from our beneficiaries as we teach them. Okay, next slide. So what are we asking of our beneficiaries? Many of these things seem pretty practical, but sometimes we do expect them to, once they receive this education, to become responsible for looking at self-management behaviors and incorporating them, understanding how to use their medication safely and effectively, performing self-monitoring of blood pressure and blood glucose, understand how to prevent, detect, and treat high and low blood glucose, and on to developing the personal strategies to address their psychosocial issues and concerns and promote health and behavior change. An example of this would be in some of my classes, it becomes very real on why they should be logging their information when they're monitoring, and the glucose sometimes they felt like that was an unnecessary step, or it was too much of a bother, or they would just let the machine catch it. But when they started to learn to log, they could see that medications and maybe comments about what their blood sugar was at a certain time, that they could make some changes and talk with their provider, and that maybe another medication was indicated, or they needed to restructure how the medication was done. So there's a lot that we're asking of them, but we want them to be able to become comfortable in talking with their providers as much as possible. Next slide. So we always want to encourage team care approach for diabetes management. Patients who receive this diabetes self-management education have improved use of primary care and preventive services. They're more likely to take their medication as prescribed. They have better control of their glucose, blood pressure, and LDL cholesterol. So those are some of the big ones, and we certainly want to reduce those microvascular and macrovascular complications and other complications such as nerve damage. Next slide. So how does the team care approach for diabetes management work? A team approach to diabetes care can effectively help people cope with the vast array of complications that arise. People with diabetes can lower their risk for microvascular complications such as eye disease and kidney disease. The macrovascular, like I was talking about, heart disease and stroke, and nerve damage. And they do this by looking at and controlling their ABCs, the A1C, the blood pressure, the cholesterol, sort of like the schematic with the cardiac disease and similar, smoking cessation. Following an individualized meal plan, engaging in regular physical activity, avoiding tobacco abuse, taking medication as prescribed, coping effectively with the demands of a complex chronic disease. So all these things, we encourage them to let the team and their providers assist them in managing this. Okay, next slide. Okay, so how does the team care approach for diabetes management work? Patients who increase the use of effective behavioral interventions to lower the risk of diabetes and treatments to improve glycemic control and cardiovascular risk profiles can prevent or delay progression to kidney failure, vision loss, nerve damage, lower extremity amputation, and cardiovascular disease. Some of those same things that I was just saying. Next slide. This is a little table on, sometimes we get confused on the DSMT, which is the Diabetes Self-Management Education Training, and then the DSME, Diabetes Self-Management Education, the DSME. The DSMT is billable to CMS because that is a provider staff that's treating the patients, and they can bill for those services, and they're usually taught by clinicians, unless it's a CHW, that clinical community health worker that's working under the provider and is supervised by the clinician. They're mostly clinical, but increasing in community settings, and they provide enhanced and individualized treatment to patients and can be taught to individual patients or in a group setting. As opposed to DSME, it is not billable to CMS. The QIN, QIO staff do not treat patients, therefore providers can't bill for our time with the patients during the workshops. They're taught by anyone who is certified in the program. It's mostly community settings, and it provides tools to help the patients with self-management in the group setting. Next slide. Some of you may have seen this information. To me, it's very important that this information continue to go out, because as we know, what we discovered in the first couple of slides is that we do have an increase in diabetes, many in pre-diabetes that don't know about it. Therefore, the lifespan and advocacy of diabetes self-management education is broadened and widened because the age of needing education over many years of life. So there are 4 critical times to assess, provide, and adjust DSME. And the first thing you want to consider is there a nutrition? Is there nutrition that's needed, maybe? Or is it education, or is it emotional health? And it may be all 3. But the critical times that you would want to really consider when you're referring to DSME would be with a new diagnosis of type 2 diabetes annually for health maintenance and prevention of complications. 3, when your new complicating factors influence self-management. And 4, when transitions in care occur. Included below are the DSME's algorithm of care and action steps. So that's on the next slide, please. So it's a little hard to see, but what it mainly is saying is that at diagnosis in the primary care, or endocrinologists or clinical care team, you want to be able at diagnosis to answer questions and provide emotional support regarding diagnosis and provide overview of treatment and treatment goals, make the referral, teach the survival skills, and there's so much more of areas of focus and action steps that can be taken. You will have this information on the slides. And then going into the annual and complicating factors and transitions, there's just key factors that may trigger another referral to DSME. And of course, DSME right now with our program and everything is free of charge, and we don't turn anyone away. Next slide. So this is our diabetes self-management education brochure made easy. Setting up a class is easy as 1, 2, 3. It's a little schematic about the class breakdown, like I talked about earlier, with it, 1 day a week, 6 classes, and for 1.5 to 2 hours. There's the curriculum listed on the right-hand side, and to host a class or to become a trainer, we'll be glad to talk with you about it. You do not have to be a clinical person to be trained. However, we do have quite success with our clinical folks as far as becoming peer educators. Okay, next slide. This would be in setting up a class, secure a location, recruit your participants, encourage others. So there's several, we can give you helpful tips on how to continue to grow these classes, how to improve it within your community, collaborative efforts. We have a couple of successful collaborative efforts going on in the state of Louisiana. So if you need any information or help with that, we'll be glad to provide that to you. Okay, next slide. Natalie Tapp and Susie Sims did a really nice video describing EDC, and it just can be used in a variety of ways. I wanted you to be aware of this. It can be used in recruitment, explanation of classes, maybe to create interest when you're talking with administrative staff, and that sort of thing. So if we could play that quickly, it's just a couple of minutes, please. Thank you.
Can you confirm that you hear the music?
Everyone with diabetes counts is part of a national initiative, and it's funded. Quality Insight Quality Innovation Network. The classes consist of generally 5 to 6 workshops and last about an hour and a half to 2 hours. A lot of times people don't even know what diabetes is and what it entails. How much does it take out of their day, out of their life to manage their diabetes? We teach things such as what is diabetes? We also talk about complications. As I always say in my first class, diabetes is an equal opportunity disease. It affects every organ in our body. Then we also talk about monitoring, how to correctly take the blood sugar, use your monitor. Does your monitor work correctly? Are your strips not expired? How often should you test? When you should test? We offer blood glucose log recordings that we encourage the patients to give to their physicians to look for trends, to see if there's a reason that they need to change their medication. Segueing into medications, we have a module on medications because there's so many different medications out there, so that they know and understand what this medication does to them, or what the side effects are, or how long does it last, especially when talking about insulin. We do meal planning with them. We look at fast food restaurants, options for eating a healthy meal if you have to eat a fast food meal. Do we think when we teach these classes that the diabetic is never in their life going to have a chocolate chip cookie or a piece of apple pie? Absolutely not. Our goal is to, if they do choose to eat a chocolate chip cookie or a piece of an apple pie, then modify what you're eating during the day. We teach them how to do that. And lastly, we talk about stress management and depression, exercise, how these things are all intertwined. Just because you're a Medicare beneficiary and you might be elderly doesn't mean you can't exercise. You can sit in a chair such as this. We can do resistance training, how we can do walking, how each little bit helps in the management of diabetes. My family suffers with diabetes. It's helped me to learn that I need reduction in my own life. That's one reason why I think what I like about the diabetic class. I would encourage people to come and to bring someone with you. I have been able to treat my diabetes with my diet. I've cut back on the amount of food I eat, and I've lost weight. Everything, doctor said everything is doing good. I'm a nurse practitioner, and I thought I'd know everything. But I've learned a lot of things and reinforced things that I've known. When you're on your own and you don't have a support group, lots of times you just do what you think is the best way. But coming to a class like this, it really reinforces the importance of everything you need to do to keep your diabetes in control. It helps people within our own communities learn to take care of their own health. Everywhere you turn, someone has diabetes, a family member, a cousin, a friend. By having these classes and reinforcing this education and being able to make it a community-wide effort, people are going to start to see the importance of managing their health. Because if we don't manage our own health, there's nobody else that's going to do it. We also involve caregivers. We also involve their spouses. We also involve their grandchildren, their children. So as a community, we're taking care of our own health and well-being. So if you're interested in everyone with diabetes, Carol, or to register for one of the classes, how do you get a hold of us? Simply call the toll-free number 855-376-9382.
Okay, so we can I'm sorry about the volume. Sometimes it's a little, when you're trying to put this over another media, it sometimes isn't as clear. But we do have that available, and it's just a real brief description of the program, and we'll be glad to forward that link and stuff if you need it to, help be able to discuss ADC and D. We've used it several times, and it can be used in a physician's office or whatever to maybe facilitate some interest, for classes and things like that as well. So, okay, I think that's it for me. How about questions? Does anybody have any questions?
We do have some questions here. The first one is, if you were a small adult primary care practice, what processes would you recommend to develop and implement a diabetes care program or guidelines?
Okay. There's a couple of things that I would consider. Number one would be, have you identified a diabetes champion that maybe could help be the lead person that can coordinate the activities that go into it? The next thing I would look at is looking from a CMS standpoint, the measures that you would like to accomplish for your diabetes. Take a look at assess the diabetes patients that you do have, looking at your data. What is it, A1Cs, blood pressures, maybe looking at the measures so that you can incorporate your MIPS and things like that into your work. Also, the thing that I would suggest is after you do all that, is then start talking to your beneficiaries. What is it that you think would help you the most as we go through this process? And find out, is education DSME? Are there transportation issues and things like that? Now, incorporating it into your office, there are several things you can consider. Workflow. What is the best way to handle, your first-time diabetic patients when they're diagnosed, and the education process and the referrals that need to be made. You need to allow more time and things like that. So working with your staff to know time allowances for those type of patients and stuff. Okay.
Okay. We have another question. What are the benefits for the care team when they implement clinical guidelines in their practice?
The benefits of the care team, when they're implementing first of all, you're going to see improved outcomes for your patients, hopefully. If you're implementing key strategies and the referrals of DSME, the measures you want to take a look at, are they getting their lipid profiles, A1Cs and staying within range. You're going to have a happier, satisfied patient because they're going to feel like that they're cared for. When we're meeting measures and and you're looking at them holistically, taking into account their diabetes issues, complications. When you look at diabetes, it affects the whole body, and it affects, as we were talking about from an educational standpoint, emotional needs, physical needs, and things like that. So it becomes really need a holistic approach, and then that turns into a satisfied patient whenever you're able to address those needs. And that should, from the caregiver standpoint, and were you saying caregiver from a beneficiary caregiver or the staff, provider staff? I guess I need to clarify that.
It was the staff.
Okay. All right. Yeah. So I have a couple of questions too. First of all, back to Kevin. You talked about the monthly webinars that you do as part of the hypertension program. Are those taped? Are they available after the fact? So if a practice hasn't been participating, go ahead.
That's a great question. Yes, the majority of them are taped, and they're put into my quality insights. There's been times, as the ones I mentioned with Dr. Janet Wright from the Million Hearts, where we don't even have them live. Dr. Wright, enjoys not having the pressure of recording it live, and we can stop if she wants to. So we just go ahead and record it, and then we post it.
Great. That would be great, because if people sign up now, we wouldn't want them to have missed all the great content that came before.
Oh, absolutely.
Yeah. So, and then for Karen, I had a question, and that is, again, because the Quality Insights Quinn QIO is, you're covering certain states, and we know that Maryland and Virginia, where we do have some practices, are covered by health quality innovators. Is the DSME program available through every Quinn QIO? So it would you would have a counterpart there they would contact to help them set up the actual education, or can they still reach out to you, or how would they handle that?
Glad you asked that. Each state does have their own network of QIO, Quality Improvement Network. And so they would need to reach out to them. Now, as in one of the slides that I showed, it may not be deep. It may be something very similar, like the Stanford curriculum or Gateway curriculum. That's a little bit newer curriculum. But deep is what we had decided on, at the beginning of the project and everything. So that's what I know for sure. We do that in West Virginia and Louisiana. So, and then they do have some Stanford training as well. But anyway, yeah. So they would need to reach out to them, but it is available.
So then I have just a couple things to add, because I know we're over time, but I wanted to point out two things. First of all, in your handouts pane right now, you can download the handouts from this presentation, as well as the YouTube subscription information if you want to replay this for other members of your staff. The links to both of our speakers. Their addresses are on those handouts, as is the link to that little video, which I think would be a great thing to share with patients to explain the program to them. The other thing is that we will follow up as a PTN with Health Quality Innovators to see if there's a centralized number that people could call to get hooked up with them. I'm more concerned about our practices that are across the bridge, and you know who you are when I say that, not on the peninsula, because on the peninsula, I do know that on the lower counties, the MAC Center, which is the Area Agency on Aging Center, does do diabetes self-management education free of charge as part of this program. So they are already available in your community, and I know we have Jill Kenny from that organization starting to come out to practices and explain what they have available. So when you get your follow-up email to this particular session, you're going to get some information on that. And, you know, I definitely recommend that you follow up with them to get involved with that. And just the final thing I would add is, for those of you who listen every month and you know that Valencia is normally our facilitator, Valencia actually is right today at Diabetes Self-Management Education Training at the MAC Center. So, you know, we're hoping to help and support them with having her also be an educator for that program. So lots of great things to come and lots of great information. I do have one final polling question. You can answer it and then you can sign out. Let me launch it. And basically, it's just about the diabetes management education. What I'm looking for is, if you are out there and you want to participate, you know, choose one of these. You're a Delaware or PA practice and you will contact Quality Insights to participate, or if you're a Maryland practice, you would like us to contact you to get you connected to the right people to help you provide the diabetes support also. So, again, thank you for joining us today. If you haven't voted yet, please vote before you sign off. Otherwise, everybody have a wonderful afternoon, and thank you again, Kevin and Karen, for participating and providing us with such a good presentation. Thanks so much.
Thank you.
Thank you.